Thank you, Diego, and thank you for everybody who showed up to this morning. I know I'm a little bit different speaker than you guys normally get at Game of Thrones, and I have been really fortunate to sit in the audience on the other side of this going, oh, there's a lot of stuff I don't know. And so I figured that coming from a frontline physician, there is probably a lot of stuff that you guys don't know about how things actually work in your hospital systems, what are the barriers to getting some implementation of really cool programming done, and how you guys can help us build a better community to fight really big problems. So with that, I wanted to introduce you guys to kind of a new approach and some of the ways that we're looking to break down the silos in healthcare, specifically around the opiate crisis. Who here knows that we have an opiate crisis in Nevada? Yeah, right? Oh my God. Okay, we're gonna talk about some numbers here in a second, but this is a problem that affects everybody. This is a problem that is not going away. And if you've seen the most recent CDC numbers, we are one of 5 states where our overdose deaths are still going up in the country. So despite a 15% decline in overdose deaths in the rest of the country, we are still going up, and we are second only to Alaska in those numbers. So those numbers should scare you. Those numbers should say we need to do something better. There's a lot of people throwing a lot of opiate money around, and we have a lot of people working in silos that are doing fantastic work, but we're failing on the back end to help connect the dots and put the pieces together. And I hope that you will leave here today with an understanding that some of us are committed to connecting the dots for you and literally hitting the easy button for things that are gonna cost you $0 out of pocket. Zero. Who is in favor of $0 added to your budget? Who is in favor of saving money? Yeah, I figured, right? We should get excited about that. So I wanted to do a quick disclaimer because you guys are all here thanks to grant funding and the work that is being done. So I have a colleague here, Dre Cantwell-Frank, who has been one of my champions from Bridge to Treatment. It started off as California Bridge, it became National Bridge. We added an EMS version, and she has been a huge champion, and she flew out here, she flew here from Oregon after they did a day-long statewide training for EMS initiation of buprenorphine, hospital integration of navigators, and things like that to put the pieces together. There has been a coalition of people from Nevada who have done some of that same work with Bridge, and we keep running into issues, which is why you are all sitting in front of me today to help figure out how to overcome those barriers, okay? So Dre is here. She is a fantastic resource. She has given me more stats than I could ever spend time to go look for, because thank God there are people actually doing that work that can do it. So some of the reason you're here is due to the work of Bridge, which is sponsored by the Opiate Response Network, and these are like the obligatory, yay, like here's our disclaimers. The other grant funding that we get is coming from the state opiate response dollars, and that is the Nevada dollars that were allocated towards this response. And let me tell you, if you've never worked in Grantland, it is really stinking challenging. I'm gonna try and limit my 4-letter words because this is being recorded, but for those who know how we roll in the ER, the 4-letter words they flow, so if one slips out, just smile and nod and we're gonna move on. But the SOAR dollars and the PAC Coalition, which is Jamie Ross, who's their executive director, have basically been instrumental in saying, we know the work needs to get done. We have to have a nonprofit. We have to meet all of these criteria, and nobody's putting the system together. So I said, Jamie, I had to turn down $150,000 because we didn't have resources, and I couldn't get the resources through fire to do an overdose response vehicle because we're short paramedics. Okay, pivot, now what? I'm one person and I work for a for-profit physician group that staffs a for-profit hospital. How are we gonna do this? And she goes, I don't know. And she was willing to sit down in a room and said, okay, we'll co-do this and you'll just be a subcontractor and we'll plow it through and I will hold on to your work. Or I will sponsor and I will be the pass-through to help us get this work done. So I owe a immense amount of gratitude towards Jamie Ross and the PAC Coalition for basically making this work happen. So that's your obligatory statement. So obviously we said we have a problem in Nevada. These are statistics, and I can thank Brandon Alisi at Southern Nevada Health District for giving me some of the most kind of up-to-date data. These areas in the dark blue are the areas of highest overdoses. And this is the death rate. And what you don't see is that area code 101 is the highest. Does that surprise anybody? No. Why? What's down there? Name some places that are down there. Yeah, rescue mission, the courtyard, most of our resources for unhoused people in the entire county are in that one zip code. Okay? So this is something that continues to happen, but Henderson's got a really blue area, if you notice. North Las Vegas, hugely blue area, right? Like, this is not an isolated problem. Okay? These are some more statistics. 72,000 hospital encounters. Okay? Like 52% of those patients that have substance use disorders or that are presenting for that have Medicaid. Who's looked at the federal budget? Is anybody concerned about the cuts to Medicaid and what that is going to do for access to services to these patients? Where does everybody go when you don't know what else to do? Where do they land? The ER. What do they call? 911. Do we have a paramedic shortage? Does anybody know? The answer is a resounding yes. We are looking at changing response models to try to figure out how to get the right care to the right person in the right time. This is a massive problem. And it is time that we come up with much better solutions. So cool. These are a lot of numbers. Who here has personally been affected by somebody with an opiate use disorder? Anybody? Raise your hands. Okay. That's less than I thought. How about any other substance use disorder? Alcoholism? Was it easy for people to get into care? It's easy if you know the right people. 2 years ago, I didn't think that treating opiate use disorder was a me problem. 2 years. I've learned a shit ton in 2 years. Sorry, that's just gonna have to happen. I didn't think it was a me problem. But you know what? I sort of got voluntold to do the Bridge program. I was one of the only physicians in Nevada. It was myself, it was Dr. Chris Chung from St. Rose, and that's it. And there's been, I think Dr. Dave Hart has done it from Mountain View, and that might be it. That's it. 3 ER providers have showed up to do the training to try to figure out how to put systems together to make this work better. So I didn't think it was a me problem. And I was like, oh, okay. And then I learned some statistics. I learned that somebody with a non-fatal opiate overdose has the same 1-year all-cause mortality as somebody with a non-fatal STEMI. We're pretty aggressive about how we treat STEMIs, right? Does everybody know what a STEMI is? Okay, so STEMI is like the big heart attack that you go directly to the cath lab. But like do not stop, do not pass go, relatively high mortality rates. Like it's the one that we care about the door to balloon times, and we care about having cardiology teams and all that kind of there, right? We do a lot of things for those patients. Our opiate overdose patients have the same 1-year mortality rate, the exact same. But we don't treat it in the same way that we treat our medical conditions, right? Our chronic medical diseases. We think that this is a problem with stigma. So this wasn't a me problem until it was. And when I learned that my job, well, I already knew this, but my job in the ER is to prevent death and dying in the next 30 days, right? That's kind of like the 30-day mark is a really big deal. And what I learned is that people that we're sending out after a non-fatal opiate overdose have a massive risk of dying in the next 48 hours. Massive. Like your highest death is in the next 48 hours after we give somebody Narcan and let them go. Yeah, highest rates. Super, super scary. And Dre will give you all those numbers because she knows them off the top of her head. I don't. But there's things we can do. So this wasn't a me problem until all of a sudden I learned it was a me problem. And then the DEA got rid of the X waiver. So now I didn't have an excuse for it not to be a me problem. And this came in handy when it was my brother-in-law. So I shared this yesterday, and we did this whole day-long training with ER nurses and EMS as we're getting ready to roll out a pilot program for buprenorphine. And I kind of teared up about it because I don't talk to a ton of people about it. But this was my brother-in-law's story. This was my brother-in-law who got started on opiates after a car accident and whose parents read the instructions on the bottle and gave him the oxycodone just as prescribed on the bottle once every 4 hours. And in that one encounter, we created an opiate addict. We created a person who was addicted to opiates. And that persisted for 15 years. 15 years. On, off, tried to get help, tried to get to treatment. It worked for a little bit, it didn't work. Life circumstances happened. He had been doing really well. for a period of time, and then his mom died suddenly. And within a day, he was back on drugs. And thank God he'd been fortunate enough to have kind of walked the walk a little bit. And I had reached out over years. Like, I have known this kid for 15 years, and I have said, listen, when you're ready, I'm here. I didn't know what that was supposed to look like. I didn't know who the hell I was going to call, but I said, when you're ready, I'm here. And about 10 days to 2 weeks after his mom had died and after he was back on stuff, he said, I'm either going to kill myself or I need to get help. And I was like, whoa. And I was sleeping because I was working night shifts at the time. And so I was in between nights because that's what you do. We sleep during the day and we don't answer our phone. And thankfully he called my husband. And he said, I need help. And that was the first time. And you know what we did? We went and we picked him up where he was. We brought him home. We said, what is it that you need? Where are you at? James came and woke me up. And he said, okay, like, it's time. We got to do the things that you've been working on that aren't in place yet and stuff. But like, this has got to happen. And my brother-in-law today has been sober for the last year and a half because I was able to pick up the phone and call my ER colleague and say, Zach needs loaded on bupe, and then I need to get him into help. And we got him loaded, we got him treated. I picked up a friend and I called Dr. Jose Partida Corona, who's one of our addiction colleagues in town. And I said, Jose, I have a huge favor. I need to get my brother-in-law in, and he doesn't have insurance, and I will pay for it, but like, I just need somebody to get him help. And Jose, once he landed, because he was on a plane in New Mexico, said, I'm back in 3 days, like, call the office and I will of course see him and we will just make it work. And he just eloped and got married, I found out this past week, and is doing really, really well. But that's my brother-in-law. So we don't care until it happens to us. But every one of these numbers is an us for somebody. It is somebody's person. And Dre and I were sitting around my kitchen like landing pad, because my island is ginormous and it looks like a helicopter landing pad. And we were talking last night, and she told me a story about a CEO of a hospital in Alaska who said, opiates and substance use patients are not what we want here. This is not what we do here. Except that her child died of an opiate overdose. And then all of a sudden, they were 100% on board. Within 6 months, there were programs in the hospital, there were navigators, there was everything you needed, because it wasn't an us problem until it was. So that's why I was curious as to how many in the room said it's an us problem. This is somebody I know, because there are several people in our community who've been very forthcoming about their family member struggles with opiates. Marilyn Kirkpatrick has been a very big proponent of getting systems in place because she's had loved ones that have been affected. And so she is a huge champion in our community, right? Like, it does. It's our neighbors, it's our friends, it's our children, it's our relatives. These numbers belong to somebody. And so that's why we're here to talk about what this can look like. So it affects the hospital in general, right? Some statistics. 1 in 11 patients in emergency department visits for adults are patients with substance use disorders. Roughly 10% of your patient population has a substance use disorder of some sort. And actually, some of the screening questions in more recent data suggest 28%. 28% of your patients who present to an emergency department will screen positive for a substance use disorder. So you can say this is not an us problem, but they're already there. Okay? 11.9% of all hospitalized patients have a substance use disorder, most of which is undertreated or unrecognized. You want to know why patients leave AMA from the floor and they don't feel like their pain's being treated or they feel like people are being mean? This is a big risk factor for it. Okay? Admitted patients with substance use disorders have longer lengths of stay and higher readmission rates. Who gets paid for a 30-day readmission for the same problem? Nobody. Does that hurt your bottom line? If we can make that number go down, would that be a good thing? That's what I thought. Untreated withdrawal increases stress and anxiety for patients and caregivers. It causes conflict in our hospitals. Do you think that patients who are in withdrawal symptoms or don't feel understood by their healthcare providers are problem patients in the hospital? Kinda. Does it lead to your staff having decreased morale and some burnout? Absolutely. Do you think that this is a problem for us in the ER? Yeah. These are my hall patients every day. These are my patients in my halls every single day. but we can do it better. Okay? Challenges that exist in the system. Stigma being a ginormous one. But stigma, as Dre actually talked about yesterday, is usually a reflection of problems that we have internally. Our stigma usually comes from some other personal experience that leads us to believe that this is somebody else's problem. We externalize that. Stigma is a ginormous problem. We change the way that we talk about patients with substance use disorder. It is a person with a substance use disorder. It is not an addict. It is not a junkie. It is a person. And when we switch the way that we talk about this to a person-centered approach, we will do better. The disconnect. Our addiction colleagues have been going, we want patients. Please, please send us patients. And guess what hospitals have? Patients. We have patients who need care. Guess what they're not getting? Point A to point B to get the care they need. They're not. They're absolutely not. Who here has social workers and case managers? Every hospital has a social worker and a case manager, right? Do they work 24/7? Do they? Okay. It's like a relatively rare thing. Most don't. Are they in the ER? Helping us at 2 o'clock in the morning on a Saturday? No, there sure aren't. Guess when I see a lot of my patients? I mean, I've done 12 full years as a pit doc in the ER weekend nights. Guess what resources are not available for my patients? Right? So there's a huge disconnect in getting patients from points of crisis, which is what we see in the 911 system and in the ERs, to outpatient treatment. I don't think that ideally we want to do long-term detox and all of this like chronic management of patients with substance use disorders in an acute care hospital. But we sure as heck are not getting them where they need to go. And then I think lack of understanding. There's lack of understanding about how this can actually be reimbursed, what CMS allows to be billed, how we can actually like capitalize on some of the available revenue that's available, and we can do it. So I think that there's just like a lack of understanding on this topic, which is why you're all sitting here today. All right, God bless our folks in California. I know we are in Nevada, but listen, they did it first, so they get to name the process, okay? So their model has come out of finding a clinical champion that starts treatment immediately. That looks like somebody like me. That looks like EMS, okay? That's most likely what that is. And then we need to link them. So who here has ever heard of a peer support specialist or a peer navigator? I've got three hands. You don't count. We only have 3 hands in the room, okay? Who here knows what a community healthcare worker is? Okay, a few more, yay. Cool. The overlap is really similar between a peer navigator and a community healthcare worker, and a lot of times they're actually dual credentialed. Can you bill for a community healthcare worker? Uh-huh. Can you bill for a peer support specialist? Uh-huh, you can. It's not great. It's one of the, it's actually really pretty crappy rate, but it is a billable service. But you know what? The counseling and stuff and the initiation of buprenorphine is a billable service. There's ways that we can recoup costs, okay? So the navigator has been one of the biggest missing pieces here in Nevada. It's not that we don't have them, it's that we can't get them integrated into a hospital. So UMC had a great program with Track B that lasted 1.5 to 2 years. And one of the problems that happened was that it was just grant funded. And we didn't have buy-in from the C-suite to continue the program because, again, you have to make the numbers match. Like, I get it. I own a business too. Like, you got to make the spreadsheet work, right? So that program got discontinued and they no longer have a navigator. Until next week, there has been a gap for about 1 year to 1.5 years of not having any peer navigators in ERs to connect patients with substance use disorder to outpatient treatment. Do you know what we have to do instead? We have to put patients on a legal hold. We have to put patients on a legal hold to get a psychiatric assessor out to say, yes, this patient probably doesn't need inpatient psychiatric services. What they really need is drug rehab. They need detox. They need help getting there. But when I pick up the phone and I say, hey, do you have any beds? The answer is no, because they're capitated beds. Because they're already reserved, and the only way I can get somebody from point A to point B is by putting them on a legal hold. Who likes legal hold sitting in the ER? Nobody. I don't like it. Do we think that's good patient care? No. What do we rank in terms of mental health care in the state? In this state, do we know where we're at? Bottom. Like dead stinking last. Like I think we made it up to 47 and now we're back down to 51. Yay us. We can do this better to free up the right resources for our real mental health patients that helps divert our substance use patients to where they actually need to go. Okay? The last person in this is the patient, because this is why we're doing it. We're doing it for the person on the other end who deserves to have better care. And there's some really cool evidence-based guidelines that we just have kind of ignored. We said, cool, it's still not an us problem. Ugh, I don't know what's going to happen. I can't get them to follow up, so I don't want to follow it. That's bullshit. It is. So we expanded on the California Bridge model, and we said, guess what? We're going to get EMS involved because I can help drive change with EMS. I can start a process that then I can hand off to the hospitals and make even faster to expedite the care for these patients. So there are lots of places around the country that have started giving buprenorphine in the field. Is anybody familiar with the medication buprenorphine? Like a couple. Okay, there's a couple. So I'm going to give you like the really quick thing. So fentanyl, oxycodone, methadone, all is a full agonist. It's basically like, all right. It's basically like if you imagine your tooth sitting nice in a socket, right? That's what your mu receptor, which is your opiate receptor, looks like when it's happy and filled. It says, yay, everything's happy, right? What happens with Narcan? We know what Narcan is, right? We've done enough public education in Narcan school. Okay, so we've got a full agonist, which is your fentanyl, which is your methadone, Dilaudid, etc. We've got naloxone or Narcan, which is a full antagonist. It basically is like a pair of pliers that rips your perfectly good tooth out and leaves the nerve root screaming and exposed. Okay? Right now, that's all we're doing for patients, for the most part. We're saying, hey, we took you from a really happy place in your opiate haven and your overdose, and we gave you the medication that's going to keep you breathing, but is going to make you feel like garbage. So not only have our overdose patients had low oxygen levels and are hypoxic, which causes agitation and confusion in and of itself, we've also said, hey, we ripped out that perfectly good tooth, and now all you can think about is how much pain you're in. Who's needed to go to a dentist emergently and you know how bad that dental pain hurts? Can you think about anything else? No, all you need is for somebody to make it feel better. Buprenorphine is really cool in that it basically comes back over that exposed root of that nerve socket and covers it, but not completely, and it binds tighter than anything else. It says, this is like the dental wax. I'm now protecting that nerve root. You now feel a lot better, and it lasts and it binds to that receptor for about 24 to 36 hours. It will prevent the person from overdosing for the next 48 hours. What did I say was the most vulnerable time for these patients? 48 hours. So here's what we've kind of decided with EMS. I don't care if the ER doesn't do it. I don't care if we can't get somebody into follow-up. If I can keep somebody safe for the next 48 hours by giving this medication in the field after an overdose, I'm going to do it. Because that person deserves a chance to live for the next 48 hours. Does anybody disagree with that? Probably not, right? Seems like a pretty simple thing to do. This medicine is cheap. It's real cheap. It's about $3 a dose. $3. And you know what? People said, I'm not comfortable. I don't want to do it. It's scary. Damn near nothing. Almost nothing. There's so little side effects. You could take a 30-day supply of this medication and still be talking, walking, and breathing. It actually happened to one of Drake's colleagues. He accidentally took all 30 days in a panic. The colleague did. The patient did. Let me clarify that. Yeah, sorry. His patient did, and kind of got in a moment of panic and took an entire 30-day supply of this partial opiate agonist, right? Because everybody's like, oh, it's still a controlled substance. It's still kind of crazy. Took 30 days worth and walked in going, why isn't something else happening? Can't do that with Tylenol. Can't do that with ibuprofen. Can't do that with damn near most medications. So the safety profile is insanely safe. There is zero reason not to do this. So we just said, okay, we're gonna kind of push things along and we're gonna start it in the field. And then we're gonna make it really easy for the hospitals to get on board and help us in this mission. So that's what we're doing. So Las Vegas Fire and Rescue and Henderson Fire, probably starting Q3, are about to launch a buprenorphine trial in the field to try to help move the needle on this. So we're going to give bupe in the field. We continue to do leave behind naloxone. The health district has been really good about doing kind of overdose kits, and naloxone is very easily available. Transport to the ER or alternate facilities. Right now, is anybody familiar with how EMS gets reimbursed? One person. Yep, I figured you did. EMS only gets reimbursed based on the level of the provider in the back of the ambulance and how many miles it was to the ER. That's it. Has nothing to do with care, has nothing to do with all the things we did to save your life. And if you don't get transported, you don't get reimbursed. And there was an ET3 model that looked at especially some alternate destinations, some treat in place. There's some fancy language we're working on trying to get around using that will allow better alternate destination transports, because instead of going to the ER, if we can load them and get them connected, wouldn't it be great to get somebody to an actual sobering center or detox instead of coming to the ER? But I can't get reimbursed for that in EMS right now. So we got to keep thinking, okay? And then the warm handoff. Bupe saves lives. Ooh, good Lord. Sorry, I thought that. So in the general population, is anybody familiar with the number needed to treat? It's a big fancy scientific medical term that basically says how many times do we need to give a medication to have somebody live, okay? Aspirin, probably the most famous number that people know. Aspirin, how many times do we need to give it in ACS, which is acute coronary syndrome, to save life? It's 42. How many times do we need to give a steroid in acute COPD to keep that patient alive? It's 10. How many times do we need to defibrillate somebody in VFib to keep them alive? We have to do it 2.5 times to save a life. Do you know what the number needed to treat for buprenorphine is at 16 milligram concentrations and above? 2. We need $6 to save 1 in 2. Those are pretty stark numbers, right? This is an evidence-based thing, and buprenorphine saves lives. When we talk about patients with MOUD and patients receiving treatment with MAT, patients without MAT, which is medication-assisted treatment, which are things like buprenorphine or methadone, they are 6 times more likely to die. 6 times from all causes, okay? Or, I'm sorry, that's patients without OUD and no treatment, sorry. Oh, these numbers got really light. Anyways, sorry, people with opiate use disorders and no treatment are 6 times more likely to die. Your general population is 1. People with OUD receiving MAT, it's 1.8. So you lower their risk to damn near the normal rates of death. Sorry, that didn't show up as well. This was a last minute change on my slides because I was having a crisis this morning. So that's what those numbers look like. Okay? So what may be coming down the pike? So the DEA has already removed the X waiver. The DEA has said, if you have a license to prescribe, then guess what? Here's 8 hours of training you must do. Every single person that prescribes any medications has to do an 8-hour training. So there is no longer an excuse of oh, I'm not comfortable. Oh, I don't know enough. The DEA has said, guess what? If you're going to renew your license, you're going to be. So they've set the stage. ACEP, which is the American College of Emergency Physicians, NAEMSP, which is the National Association of EMS Physicians, and a lot of other groups have said this is a standard of care. There's no questions, this is a standard of care. So guess what they're doing? They're setting the stage for value-based metrics to come. I've talked to a handful of people who work with some of our insurers, and when you look at, you get paid based on bundles of care, right? Sepsis, STEMI, CHF, community-acquired pneumonia, right? You have metrics that you have to meet, and that dictates partly how you're reimbursed? Yes? Listen, I don't do billing, I just show up and treat patients. So if that's wrong, help me a little bit, right? But those bundles exist, right? You have to check the boxes that you did all the things. Well, we're not doing any of the evidence-based things, or very few of us are doing the evidence-based things in the ER, and our numbers are still, our death rates and our overdoses are still going up. So do you think that they might, here's the carrot, do all the things that we want you to do because it's the right thing to do. What sometimes comes behind the carrot? You're going to do it. So guess what? Your reimbursement is soon going to be tied, potentially, to did they get buprenorphine in the emergency department? Did they get connected with a navigator? Those are really easy things. I had one more thought on that. Where'd it go? Okay, anyways, those are really easy things. These are all the ICD-10 codes that can be billed related to opiate use disorders. There's a boatload. So guess what? There's all kinds of things that we can do. And this is where I'm going to need your help here in a little bit. Okay? So changes that are already occurring. SB 325, which was passed in 2021, allows pharmacists now at any pharmacy to de novo, meaning start from scratch, a prescription for buprenorphine. So that is a non-physician, non-prescriber technically starting this medication because it's that safe. Now, it was really cool that this initiative came in. I think that there's a lot more work that needs to be done on it personally. The regulation passed in 2023. I don't know a single pharmacist who's ever written a prescription for buprenorphine. So we can do what we want to on the legislative side, but the implementation we're really lacking on, okay? The things that are coming is, again, like some of these updates on the return on investment. They've just made changes. I believe Medicaid made changes last year to like some of the outpatient treatment centers and stuff like that, and the IOPs and all the things, all the initials I don't know because that's not in my world normally. But they've made changes to increase reimbursement for these types of services. So I would imagine that those might trickle down to the hospitals as well. One of the things that we can do that's pretty easy is to add a delineation of privileges to our bylaws for addiction services. There is not a single hospital that I am aware of right now in town that has an addiction medicine consult service. And there is no delineation of privileges. And as we are seeing more patients on things like buprenorphine and methadone to treat opiate use disorders, we also need to be able to have a phone a friend line that says, hey, things are a little bit complicated. My patient on methadone or on buprenorphine is now needing to have surgery and they're in the ICU and I need help navigating how to treat pain effectively and keep somebody in remission or in recovery. But we don't have that infrastructure right now. Telehealth has been approved for navigation services. It has also been continued and approved for buprenorphine. So we have the ability to use telehealth still to continue to combat this. So statewide solutions. I think that there's a lot of talk about these things. I would argue based on the numbers that substance use disorders are considered a life-threatening condition, right? Is that a fair jump? Yeah, and we are the only point of care available 24/7. So who knows about EMTALA? My favorite, right? A few of us know about EMTALA. So what do we need to do based on EMTALA for a life-threatening condition? Treat regardless of the ability to pay. What else do we need to do? We need to identify life-threatening conditions and we need to stabilize them, right? We have a moral and ethical obligation in line with EMTALA to treat these patients. And my challenge to you is, have we really done our job in stabilizing these patients? Have we met our burden by EMTALA by letting an overdose patient walk out the door with no connection to resources, no medication that could save their life? We don't let diabetics and borderline DKA sign out and at least not give them a prescription for insulin. We don't let the acute heart attack walk out the door and say, at least here's your statin, here's an aspirin, and here's your beta blocker. We don't do that. Right? Even if you don't want to stay, even if I can't convince you that you might die, I sure as heck am still going to write that prescription so that you have the medications that you need to give yourself a fighting chance. But we're not doing it. So have we really stabilized the patient with the life-threatening condition who we are obligated to treat by EMTALA? So we talked about buprenorphine as the standard of care. One of the really cool things that came out is that when you look at patients started on buprenorphine in the emergency department versus patients who were started within 24 hours at an outpatient detox center where they did addiction treatment and stuff like that, when they looked at 30-day retention in treatment programs, the group that got buprenorphine in the emergency department were 78% still in treatment at 30 days. Only 37% of patients who had to get the buprenorphine the next day with less than 24 hours were still in treatment. So the earlier we give the medication, the better patients do at a 30-day outcome. Like, the numbers are crazy. There's no reason to not do this. Peer navigators. Patients who engaged with peers were 50% more likely to be in their retention rates in treatment were at 30 days were 50%. Without a navigator, 16, almost 3 times more likely. So we're not stabilizing the acute medical condition when we're not connecting patients to navigators and when we're not giving buprenorphine and when we're not giving people a chance. Because most patients who show up to the ER actually want help, we're really ill-equipped to do it. So I need your help to do better. So the system that can be put in place, and here is your roadmap, and here is what I'm going to propose to you. I need more help with nursing education. I have, thanks to the Bridge Academy, 4 hours of free nursing CMEs that I would really, really, really appreciate you guys putting on your LMS systems for nursing education. It's 4 hours of free CMEs. It has to do with stigma, it has to do with buprenorphine, it has to do with the role of peer navigators and why this is an us problem. The warm handoff line. I have made it easy. It is really, really hard to put together a system when I have several major hospital systems, several EMS systems. The places around the country that have done this successfully have been one hospital and one EMS system. Guess what? That's not this. It's been a real challenge, and I think it's why we've had barriers to care. So guess what? If we can pull this off, we will be the first regional area in the country to put together a really comprehensive program. Something like that makes us feel a lot better than saying we're 51st in the nation, for mental health. We can change the needle by doing this. So the warm handoff line, one of the challenges with the navigators was like, how do we fund it? How do we keep it sustainable? All the things, right? All the bottom line things. Well, guess what? I made it easy. So we had problems, and it honestly took a phone call after a Game of Thrones meeting to somebody to get a navigator through contract. I had somebody funded for 11 months that I could not use in a hospital as a navigator because I couldn't get through contract. 11 months. It took one phone call, and magically that expedited quite a bit, so thank you for that. Because you know what? Starting Monday, I have navigators at Valley now 4 days a week in the emergency department to see patients. And guess what? I can't get that service to everybody. So here's what we did. We said, hey, navigators, I'm going to put you on telehealth, or I'm going to put you at least on a phone call, and we're going to create, similar to poison control, a number that people can call from anywhere at any time that will be staffed 24/7 starting Monday. Right now it's staffed during weekday hours and stuff, but it rings to 2 of my navigators right now. But Foundation for Recovery has said, hey, we're going to help with interns. We're going to help staff this. We believe in the mission, and we've been trying and trying to get into the hospitals, and we can't do it. So this is how we're going to do it to make the service available for everybody. Because as we've said, the patients are already in your hospitals. So this is how we can do it. And there's a whole warm line number that is active now to activate getting you a navigator either in person or at least on the line to talk to the patient in real time. Guess how much money it costs you? Thank you, PAC Coalition, SOAR Dollars, and all of the other people who have kind of like just ponied up and said, listen, we're struggling and we need to get this resource in, but here's how we're going to do it. So they have come through to help us connect the patients to care. Documentation. One of the big barriers to getting navigators in hospitals has been, well, peer navigators are usually somebody with lived experience. Sometimes that comes with a colorful background that may or may not pass a background check. It's one of the reasons telehealth is easier. People go, oh, can I really put them on my EHR? Do I want to give them access to show that I've documented that this service was actually delivered? Guess what? We're backdooring it with EMS. I can use EMS software through ImageTrend or any of the other things. There's a really cool system called ESO that does bidirectional information exchange that helps us exchange outcome data, helps us exchange insurance information, things like that. We're going to use ESO, and I'm going to build a little form that the navigators use to then push it to your hospital's electronic health records. And again, it's costing you $0. But now you have documentation that that service was delivered. So you can check that box as long as your nurses call the line and we get people connected. Okay? You're not going to be able to bill for it because you don't employ the navigators, but at least you can check the box that says we connected somebody to a navigator. Prescribing plan. Everybody should leave with buprenorphine, even if we're not comfortable, even if we're not sure if they're going to pick it up, even if we're not sure how we're going to pay for it. Everybody should leave with a script. And the challenging part has been is if you've ever talked to patients, a lot of patients with substance use disorders, how challenging can it be with somebody who maybe is unhoused, doesn't have transportation, to get to a pharmacy, have the cash and the ID to pick up the medication? We've created more barriers. So I'm going to prescribe some, I would really love to work with you guys on some blister packs and stuff, so that's coming in my last one. So prescribing plan, and then again, we're launching the EMS Bupe trial probably Q3. So it's coming, and this is your blueprint to make it better. So your return on investment. Guess what? Navigators improve flow through your hospital. It reduces your cost, it improves your performance metrics, your throughput times, it increases your provider satisfaction because we all feel like we're getting a chance to do something. We're finally able to do something that's going to make a difference. Cool, what does that translate to into numbers, right? Decreases length of stay by 1 to 2 days. Does that free up beds in your hospital to do elective procedures? Uh-huh. What do elective procedures bring? Money, yay. It decreases readmissions by 30%. Decreases readmissions by 30%, and it decreased the ICU rates for admissions, okay? On average, $17,000 was saved per patient for under 9 hours of engagement of a peer navigator. So 9 hours of working with a navigator over time saved you, the hospital, $17,000 per patient. It's a lot of money. And the navigator cost total was $343. So are you willing to save $17,400-ish for $300 of output? I would be. It's pretty good. And I'm newer to business, but those are pretty good numbers. It's a 27% decrease in costs. Okay? It improves your metrics. It decreases your AMA rates. Again, less 30-day bounce backs. I don't know all the details of like the HCAHPS scores. I'm not sure if that like plays in at all, but your AMAs and stuff are a factor, I believe. So here's my ask. I need your buy-in. I need the top level executives to buy in to this being an us problem, okay? Because what you do and what you say has clout. And your voice saying we're gonna be part of the solution matters. Because I can scream it all day long from the pit. How many of you guys have ever been to the actual ER? It's a scary place for most administrators, especially after dark and things. Like if you've ever watched some of the Instagram, the Dr. Glockenflocken stuff of like places that administrators don't go after dark, is the ER. It's fine. And it's totally okay. You know what I mean? But your clout matters with how your organization runs. I need you to help me get the education out to the staff. I understand that everybody's got different hospital groups or different emergency groups, different physician groups that staff your hospitals, but there is free education available to continue to make this happen. And we're committed to doing that. One of the other big asks that I have is I need IT help, guys. I need help from the hospital EHR side to try and help track these patients and come up with a system that says how many patients with one of the ICD-10 codes, you know what I mean? Can we track that? Did they get a navigation note? Similar to the way that we track trauma patients, similar to the STEMI tracking, similar to the stroke, all of those things. I don't need an opiate czar. I just need you guys to be willing to like create a report within your EHRs to do this. And some of that small things is like placing an order for a peer navigator. Like that should just be a standard order, or putting together the power plans or the templates needed to activate a handful of order sets to make it easy. Okay? I need help with some take-home naloxone. Right now, we are not, other than I think UMC is doing it, we are not, and Mountain View is doing a little bit of it. We're not giving patients Narcan in hand when they leave. It is one of the best harm reduction things that we can do for people is to just like, even if they're not ready for treatment, hey, I want to make sure that you have this just in case, or in case somebody you know needs it. They can get it over the counter at pharmacies, but my patients aren't making it to the pharmacy. Your patients aren't making it to the pharmacy. So how can we make sure that they're safe when they leave? I would love to get some buy-in. You know, back in the day when the DOACs were all new, the Xareltos, the Eliquis's and stuff like that, a lot of times we had starter packs that the patients physically left the hospital with to make sure that they continued on that medication, right? Are people familiar with that or know that that happened? Why can't we do that for buprenorphine? There should be zero reason that we can't put together a 3-day blister pack for somebody, slap a label on it, and they physically walk out of the hospital. You can still bill for the medication, you can still do whatever you need to do, but that keeps my patients from trying to figure out how am I gonna get to the pharmacy? What is my mode of transportation? I don't have cash. I haven't had time to figure out an ID that I lost or got stolen. But this gives them time and clarity because the giant tooth that we ripped out after their overdose has been covered with buprenorphine, and now they have a point of clarity. They have time to get on the right path. So really could use some help with that. And the last thing I'm gonna ask is that this patient population has a high risk for coexisting other infectious diseases, HIV, hepatitis, you name it. Do you know how long those tests take to get back in the hospital if I try to order them? at least a couple hours. You know how expensive they are? Really? There's like the health district has point of care testing that can be done within a minute, 1 to 2 minutes. Like it's stupid how fast these tests can be done, and we're not utilizing that. So wouldn't it be a really cool service to figure out how to loop those testing resources in so that if a patient with a substance use disorder is also found to have HIV, that we get them started on antivirals and get them linked into that care too? Because that's going to be part of their long-term recovery plan, is managing their other diseases. So that's what I'm asking. This is me. There is a Google Drive that has resources, discharge paperwork, warm line instructions, links to handouts, links to the education, and everything else that you might need. And that's my email, and that is my cell phone. Please do not like put that totally out to the world, but like that is it, and that is me. And myself and Dr. Hart and Dr. Jose Partida Corona and Dr. Maureen Strom have really been the local champions from the ER and addiction side of this to try to figure out how the heck to get patients what they need. So I'm gonna open it up to discussion, and then there's one other slide, and I'll put that back up for a second. There's a couple questions that I have, and because this is grant funded, just like indulge me for like a hot second. There's like 4 questions that say, what other barriers do you see that I don't see? What else can we do? And like, how likely are you to back this change? Just so I have some idea about how much support we actually have. Because like I said, this is the first regional approach for this. And I will thank Diego a lot for letting me commandeer this room to have this discussion, because I don't know how else to get you all in a room to really have this talk. But we gotta do the big picture thing, and we gotta not care which hospital system they land in or which EMS agency picks them up, but everybody needs to get the same care at every hospital in terms of this. Thank you.